Thank you, Anushka. My name is Akriti Tamakar, and now I'm going to go with applied aspect. So these are the topics that I'm going to cover today, starting with endometriosis. Endometriosis, it is defined as a condition where there is presence of ectopic endometrial tissue present at the site outside of the uterus, so it approximately affects about 10% of women of reproductive age group. So it has different sites of occurrence, most common one being the ovary. There are other sites of occurrence as well. Like we can see here rectovaginal pouch, pelvic peritoneum, uterine ligament, first and layer of small and large intestine, and of course fallopian tubes, of course, and vagina and cervix. There are different signs and symptoms. The signs and symptoms are based on the location and depth of implantation of the endometrial tissue itself. So the common signs and symptoms are severe pain during periods, coitus, and urination and defecation. Other non-common signs and symptoms are infertility, depression, anxiety. Moving next to the abnormal uterine bleeding. It is defined as any type of bleeding that does not fall under the normal range for duration, frequency, amount, and cyclicity. So there are different parts of bleeding there. Menorrhagia, that means heavy amount of bleeding. Metorrhagia means intermenstrual bleeding. Polymenorrhea means increased frequency of bleeding. Oligomenorrhea means decreased frequency of bleeding. So it is classified on the basis of their causes, which is subdivided into structural cause and non-structural cause. Structural cause, we have polyp, adenomyosis, leiomyoma, and malignancy. And under the non-structural cause, we have here is coagulopathy, ovulatory dysfunction, endometrial dysfunction, iatrogenic like drugs, and not yet classified. I'm going to talk only about the structural causes today. First one is polyp. So what is polyp? It's basically outgrowth of cell that are usually benign. The case is mostly presented asymptomatic, but if there's any symptom present, then it will be intermenstrual bleeding, which means bleeding between the menstrual phase. Next one we have got adenomyosis. Adenomyosis is basically presence of endometrial tissue with glands and stroma within myometrium. Another one we have leiomyoma. Leiomyoma means presence of benign smooth muscle tumors within the uterus. So it can be pedunculated, submucosal, subserosal, and intramural as well. So it ranges from millimeter to centimeter. Next one we have malignancy. Malignancy, it is so what happens during endometrial carcinoma is that there will be erosions of the outgrowth of the cell. As a consequence, there will be abnormal uterine bleeding. Moving next to our other applied aspect, we have trichomoniasia. This one is interesting because there is normal amount of shedding of the endometrium and there will be normal menstrual bleeding. But the menstrual blood fails to come out of the genital tract because there will be obstruction to the passage of blood. So one of the causes would be atresia to the cervix and upper one-third of the vagina. And with our sense, we can say that the signs and symptoms will be amenorrhea with or without dysmenorrhea. Next to our applied anatomy, we have Asherman syndrome. Asherman syndrome is also known as uterine adhesions. It is due to scar tissue formation inside the uterus due to the injury to the stratum basilis of endometrium, which is one of the layers of endometrium. Most common signs and symptoms of it would be absence of bleeding, which is also known as amenorrhea, and having light bleeding, which is known as hypomenorrhea.
The menstrual cycle encompasses two phases, the ovarian cycle and the uterine cycle. And it is normally a 28-day cycle, but it may also range from 21 to 35 days. The uterine cycle consists of three phases: the proliferative phase, the secretory phase, and the menstrual phase. From the onset of menstruation, that is the first day, from the first day to the 5th to 7th day is the menstrual phase. From the cessation of menstruation, which usually occurs on the 5th to 7th day, to the 14th day, when the ovulation is simultaneously occurring in the ovary, is the proliferative phase. From the 14th day to the next menstrual phase of the next cycle is the secretory phase. Before we dive into the uterine cycle, we must understand that the uterine cycle is completely dependent on the ovarian cycle and the hormones released from there. At the end of a menstrual cycle, if fertilization does not occur, then corpus luteum in the ovary degenerates. Corpus luteum in the ovary degenerates. As corpus luteum is responsible for the secretion of both estrogen and progesterone, the hormonal support of these hormones to the endometrium is completely lost, and this causes the stratum functionalis layer to completely shed off. And at the end of the menstrual phase, only a thin layer of the endometrial stroma remains. The negative feedback inhibition to the gonadotropin releasing hormone secretion from the anterior pituitary is lost, and this causes the release of follicle stimulating hormone, FSH, and luteinizing hormone LH from the anterior pituitary. As the proliferative phase coincides with the follicular phase of the ovary, FSH is more active during this time, and this causes the release of 4 to 5 follicles from the ovary. Among these follicles, one follicle becomes predominant, and that is converted into the Graafian follicle. Graafian follicle secretes estrogen. Under the influence of this estrogen, Under the influence of this estrogen, the stromal and epithelial components of the uterus rapidly proliferate. The endometrial thickness increases to 3 to 5 mm during this time. Also, there is development of the endometrial glands as well as spiral arteries. The cervix of the uterus releases watery mucus, which facilitates the sperm transport into the uterus, and that is responsible for the fertilization. This is the proliferative phase. Moving on to the secretory phase, which occurs after the ovulation in the ovary. What actually happens during the ovulation is the estrogen being secreted from the Graafian follicle. It provides a positive feedback to the LH secretion from the anterior pituitary instead of the usual negative feedback. So during the 12th to 14th day of ovulation, LH surge occurs. Menstrual cycle. The menstrual cycle encompasses two phases, the ovarian cycle and the uterine cycle. And it is normally a 28-day cycle, but it may also range from 21 to 35 days. The uterine cycle consists of three phases, the proliferative phase, the secretory phase, and the menstrual phase. From the onset of menstruation, that is the first day, from the first day to the 5th to 7th day is the menstrual phase. From the cessation of menstruation, which usually occurs on the 5th to 7th day, to the 14th day, when the ovulation is simultaneously occurring in the ovary, is the proliferative phase. From the 14th day to the next menstrual phase of the next cycle is the secretory phase. Before we dive into the uterine cycle, we must understand that the uterine cycle is completely dependent on the ovarian cycle and the hormones released from there. At the end of a menstrual cycle, if fertilization does not...
And at second, we discussed about the anatomical changes on the uterus, where we discussed about the menstrual cycle and their phases by demonstrating the uterus on the board diagrammatically and with the help of model and with the role play. And at third, we talked about the applied aspects, where we discussed about the endometriosis, abnormal uterine bleeding, cryptomenorrhea, and SMN syndrome. In brief, I would like to summarize the whole presentation in a final conclusion as, in conclusion, the anatomical changes in the uterus during the menstrual cycle are essential for the reproductive health. These changes are driven by the hormonal fluctuations, including the cyclic transformation of the endometrial lining, including the proliferation, menstrual, and the secretory phases. This dynamic process prepares the uterus for the potential pregnancy, facilitating the regeneration, thickening, and setting of the endometrium. Understanding these changes is vital for recognizing the normal uterine or menstrual pattern. Before we conclude, we would like to express our heartfelt thanks to our respected principal, vice principal sir, and our research faculty, anatomy department, and all the teachers present here today. Thank you for giving us such a wonderful opportunity to develop our skills and
डायबिटिक मेलाइटसमा हाइपरइन्सुलिनेमिया हुन्छ अनि त्यसले जिएनएलएच को पल्सेटाइल ग्लिडलाई इफेक्ट गरिरहेको हुन्छ नि त अनि त्यो पल्सेटाइल ग्लिड इफेक्ट भयो भने एफएसएच र एलएचएच को पनि रिलिज कम हुन्छ अनि त्यसले एमिलोरिया त भइहाल्यो नि
Actually, in case of intestinal there will be hyperandrogenism that leads to negative feedback in the uterus. You are telling about something else. I was not
there is a
रोपाई गर्न जान थालेको यिनका आमा छोरीको नसक मात्रै हो